Gwynn is a clinical pharmacist specializing in cardiology at Sanford Health with expertise in managing cardiovascular medication therapy. Daniel plays a key role in optimizing patient care and treatment outcomes within the cardiology department.
All right. Thank you for the opportunity to speak here today. How many mechanical heart valves are in the room? One. Somebody else? Pete has one, right? Okay. So would you agree that warfarin is the most inconvenient, cumbersome, difficult medication you've ever used? No? Well, a lot of people don't like it. Healthcare providers don't like it, but we've been stuck with it for mechanical valves for a long time. So I want to talk about where we've come from with valves and blood thinners and where we might be going. So mechanical valves, they were first implanted in 1960 with the caged ball valves, which, as you can see, kind of an interesting design. The ball comes up to let the blood come out, it gets trapped in the cage. After the heart is done pumping, the ball goes back down to block the hole so blood can't backflow into the heart. These are the first types that were used with any widespread use. Hundreds of thousands of them were implanted. United States stopped using them in the 1980s for the most part, but they were used in some parts of the world into the early 2000s. Later designs were very durable. Some patients had been known to have one of these valves for 40 to 50 years. So that's where we started with valves. Where do we start with blood clots? This 1977 report was about those first valves that were implanted in the early 60s. 40 to 50% of those patients had a blood clot in the first 5 years. And they estimated that 80% of patients would experience a blood clot in the first 15 years. Those numbers are huge. That is a lot of blood clots. And a lot of these patients were on warfarin, on the blood thinner. So why does this happen? Why do mechanical valves increase the risk of blood clots? Unnatural materials make the blood do funny things, and unnatural blood flow patterns. Your blood is not going through that artificial valve the way it would through your normal valve. And when blood gets caught in weird areas, it tends to form clots. So a thrombus or a clot can form on the valve and make the valve malfunction, or that thrombus can come loose, go to your brain and cause a stroke, go to some other part of the body and cause trouble. So what can we do? Improve the valves, make better valves made out of better materials. We can improve the design of the valve to have a more natural blood flow pattern, and we use blood thinners, which means warfarin for these valves. So some new designs that have come through over the years. In the 60s, a non-tilting disc valve, which is kind of similar to the caged ball, where the disc will come up and get trapped by the cage, come back down to seal the valve. Tilting disc valves, where it kind of opens like the garbage can in your kitchen. Opens to let the blood out, closes to seal the valve. Bileaflet valves. These were introduced in 1963, but there were problems with them. They stopped using them in 1965. Reintroduced in 1977 by St. Jude. Fun fact, the first St. Jude bileaflet valve was implanted on the day I was born. So I thought that was kind of fun. So this variety of valve is almost exclusively used in the United States today, and there are 3 different companies that make them. So, had that report on the early 60s valves, tons and tons of blood clots. Have things gotten better? So we have this report from 1994. Has a mix of caged ball valves, tilting disc valves, and bileaflet valves, so a good variety. We can see risk of major embolism is 4 times as high if you're not on warfarin as if you are on warfarin, and even worse for all varieties of embolism, all varieties of thrombosis. So things are better, but we clearly still need patients to be on warfarin to prevent those blood clots. So warfarin or Coumadin. It was the only oral anticoagulation medication available in the US until 2010. It blocks the production of clotting factors, which makes your blood clot more slowly. Regular blood tests, at least monthly for most patients. Frequent dose changes, which can make it very cumbersome to use. Diet restrictions, many drug interactions, And it's one of the most complicated medications we put people on. We don't like to use it, we're stuck with it. So can warfarin be replaced for patients with mechanical heart valves? Pradaxa is a new blood thinner that was approved in 2010. We tried it. We tried to use it in mechanical valves in 2013 in the Realign trial. And as you can see, warfarin patients had no heart attacks, no strokes. Pradaxa patients had heart attacks and strokes, and they canceled the study early because it clearly was not working. And the Pradaxa patients had more bleeding as well. So the answer is no. Eliquis, another new blood thinner. We were hopeful we could use this one as well. We tried it in 2023 for a certain type of aortic mechanical valve, and the results are in, and the answer is no. Valve-related thromboembolism was almost three times as high with Eliquis as with warfarin, and strokes were 2.9% with Eliquis and none for warfarin. So the answer is no. So we've tried to stop using warfarin for this, for mechanical valves, but it hasn't worked. So Xarelto is another new blood thinner. Can we use it? There's the REWA trial 5 years ago. Very small trial, only 44 patients, and the patients were only followed for 90 days. So we have to be careful drawing too big of conclusions from this. But what we see is the number of strokes, TIAs, and embolisms were actually lower with Xarelto, and no valve thrombosis happened, and similar rates of bleeding between the two groups. So very small study. They were only followed for 90 days, so we have to be real careful how we interpret this. They need to study it in a larger study. But the answer is maybe. Maybe this could happen. So future blood thinners. You might think pharmacists have a superpower of being able to pronounce drug names correctly, but the fact is when they're new, we don't know either, so I'm just kind of guessing on these. Abelacimab is a monthly injection. It binds and inactivates clotting factor 11, currently in phase 3 studies. So it's a new mechanism, a new type of blood thinner that maybe someday could be used for artificial valves. Ticafarin, similar name to warfarin, it works in a similar way, but it looks like it's much easier to control the level of blood thinning, much easier to get the right dose, and a lot less variation in how these patients can be treated. They're currently planning a phase 3 trial with patients with mechanical valves. So that's a hopeful sign. Asundexian, another factor 11 inhibitor. It is currently in a phase 3 trial for stroke prevention, so another new med. Maybe someday we can try this out with mechanical valves. And then future valves. This is the TriFlow valve by a company called Novostia. And currently underway is the Pilatus study, in which they implanted this valve in 10 patients in the last couple of years. These patients are going to be followed for 5 years with no blood thinners, which is it's a radical departure from what we've had before. It's always been unthinkable to put in a mechanical valve and not put them on blood thinners. So I'm quite interested to see how this works out. I'll be following this closely because if we can put mechanical aortic valves in people and not put them on blood thinners, that is a huge advance in the treatment of valve disease. So we'll save questions for later. Thank you.
Thank you for being a part of the Rock from the Heart community and for joining us today. Your presence and engagement make a huge difference in raising awareness and building a stronger support network for those affected by aortic and heart valve disease. Thank you so much for attending today.